Good morning, good morning. Can I ask you to move and take a seat? We're about to start in a minute or so. Thank you. Good morning, it's good to see everybody again. I hope you got some rest last night, and thanks for joining us again for another informative day. We're going to get started today with the science discovery session. I'd like to introduce the co-chairs for this particular session. Jesus Bañales, who's the head of the liver diseases group in Bioguipuzcoa Health Research Center in San Sebastián, Spain. And also Dr. Trine Folseras, a group leader in the Norwegian Center for PSC and specialist in internal medicine from Oslo in Norway. Welcome to our co-chairs, and I'm going to hand it over to them for the session.
Thank you very much, Juan. Good morning, everyone, and welcome to this early morning workshop where we will discuss the priorities of Working Group 4, which is focused on basic science. I'm very pleased to co-moderate this session with Professor Trine Folseras from the PSC Center in Oslo, and we will have the pleasure to hear from the co-chairs of this working group, Dr. Sumera Elias from Mayo Clinic, and unfortunately Luke Bolter from Edinburgh. I was not able to attend, but Sumera will present the session. Thank you very much.
All right, good morning, everyone, and thank you to the conference co-organizers for tapping me as one of the co-chairs for this working group. So as you can see here, these are the working group for the Discovery Science working group members, and this working group comprised of experts from all across the world. So while I will be presenting today, I will leverage their expertise. They're all sitting at that table right there under the floodlight, and particularly during our discussion and polling sessions. So the way we formatted our presentation is it's in 3 sections. For each section, we will review what is known in the literature. Based on what's known, what are the knowledge gaps? And based on those knowledge gaps, what are the research priorities? So we have 3 sections, 3 research priorities. Section 1 focused on the tumor genotype and tumor microenvironment, or TME phenotype correlation in cholangiocarcinoma, and there were 2 subsections for this: CCA cartography and therapeutic opportunities. So what do we mean by cartography? Cartography is an effort to build an atlas or a map of cholangiocarcinoma to really interrogate the tumor genetics and their correlation with the tumor microenvironment phenotype. So what do we know about this thus far? In the published literature, there have been multi-omic studies and molecular subtyping. A lot of this is focused on intrahepatic cholangiocarcinoma. And so, for instance, there have been multi-omic analyses that leverage tumor genetics, including transcriptomics, proteomics, and then single-cell transcriptomics. So one such analysis identified distinct intrahepatic cholangiocarcinoma molecular subtypes. Then there have also been studies that have focused on the impact of specific oncogenic mutations and how that correlates to a certain or a specific tumor microenvironment. So for instance, Dr. Nabil Bradisi's group has shown that isocitrate dehydrogenase 1 or IDH1 mutations correlate with an immunosuppressive or a pro-tumor immune microenvironment with reduced infiltration of or less numbers of CD8 T cells. And Dr. Mark Yershwan, and both are part of Working Group 4, his lab has shown that IDH1 mutations are associated with increased tumor-associated macrophages, and that promotes immune evasion and has therapeutic implications. transcriptomic signatures have also been used to correlate with response to therapy, and Dr. Chiara Bracconi's group published this showing that there's a transcriptomic signature that's linked to poor chemotherapy response, and they leveraged spatial profiling to show that there are altered tumor myeloid dynamics in these patients. Multi-omic studies have also been used to look at specific cell types. So single-cell RNA sequencing has been used, for instance, to define cancer-associated fibroblast or CAF subtypes in intrahepatic cholangiocarcinoma. It's also been used to review the transcriptional and epigenetic landscape and demonstrate that that impacts tumor-infiltrating regulatory T cells or Tregs. And there's another body of literature that has leveraged bulk transcriptomics to generate classifications that are based on the tumor microenvironment. So Dr. Daniela Sia's lab, for instance, has had put forth the STIM classification that is based on bulk transcriptomic data in cholangiocarcinoma. So that's what we know. And based on what we know, there are, as I said, there's studies that have looked at broader multi-omic analyses, and then there are there are studies that have examined specific oncogenic mutations and their correlation with the TME. So we have pieces of a puzzle. What we're missing, what is a knowledge gap, is that we don't have a comprehensive analysis of oncogenic mutations across the board, FGFR2, HER2, KRAS, and their influence on the CCA tumor microenvironment. And we don't have this across the anatomic subtypes. As I mentioned, many of these studies have focused on intrahepatic cholangiocarcinoma. And the leveraging technology, single cell and spatial technologies is really needed. We also don't have a good understanding of the link between epigenetic alterations. So for our patients here, there may be alterations in not how the DNA itself is, but how the body reads that DNA, right? So those are epigenetic alterations, and the link between those alterations and their crosstalk within the stromal and immune tumor microenvironment is not well defined. And the other thing that represents a knowledge gap in this area is the role of spatial organization. So where certain cell types are located within the tumor, and how does that relate to tumor progression and treatment response. The second subsection for the genotype and tumor microenvironment phenotype correlation was focused on therapeutic opportunities. And there have been a number of studies that have looked at a lot. This is primarily preclinical work that has looked at targeting specific cell types within the tumor microenvironment, modulating the extracellular matrix, and then examining the crosstalk between different cell types within the tumor microenvironment. So, for instance, there have been a number of preclinical studies that have examined various inhibitors, BCL2 inhibitors, growth factor blockade, and to target cancer-associated fibroblasts. There have also been studies that have examined the crosstalk or communication of CAFs with immune cells and lymphatic cells, as well as tumor cells. There have been therapeutics that have been examined in terms of their ability to remodel the extracellular matrix and make it anti-tumor, less favorable for the tumor. And there have also been some physical-based therapies. So what are the knowledge gaps? The impact of the tumor microenvironment and targeting the tumor microenvironment on tumor growth and cancer cell mutation status is underexplored. And treatment effects on the TME. So on the other hand, how systemic or local regional treatments affect TME, the various components of the TME, cellular, acellular, is unknown. So that brings us to our first research priorities. So these are linked. It's a little lengthy, and we're open to feedback on the wording. But essentially, the priority is to generate a spatial atlas to investigate cholangiocarcinoma, tumor genetics, and tumor microenvironment dynamics. And this priority has two parts: characterize the spatial heterogeneity of CCA, which would allow us to interrogate the interplay between specific oncogenic mutations, epigenetic alterations, and the tumor microenvironment. And we would have this information, or we would want to do this across the different anatomic subtypes of cholangiocarcinoma. While we're generating the spatial atlas, there's also an opportunity to analyze the paired uninvolved tissue from these patients for the presence and characterization of potential precursor lesions, which I'll review more in section 2, but for practical purposes, it made sense that if you're conducting if you're creating such an atlas, generating this, to have it there. And then the second part of this priority is that we would leverage that spatial atlas to identify novel therapeutic targets within the tumor microenvironment and guide the development of new pharmacologic strategies using preclinical models that recapitulate human cholangiocarcinoma. So that, and I think I did talk to the co-chairs. We wanted to, before we start the polling for this, we wanted to do it a little bit differently today and give opportunity for questions and discussion before we actually have the polling. And so I open the forum to any questions, if anyone needs any clarifications. So go ahead, do you have a mic? There are mics.
Can we have the lights up, please?
Yes.
Can we have the lights up?
Merck Bernstein, MD Anderson. I don't want this to at all sound negative, but many other diseases are quite large with a lot of investigation. I'm not aware of a single therapeutic implication that emerged out of TME studies. So I was curious as to why you landed on TME as a priority.
I think and I'll call on our working group as well too. Of course we know not all tumors are created equal, but we know that in cholangiocarcinoma, these are very dense fibroblastic tumors. These are paucicellular tumors, right? We don't have a lot of cancer cells because we have this dense fibrous stroma. And what is known about that stroma, what is known about the tumor microenvironment, the large body of literature, or for the large part, the literature points to a pro-tumor role of this. And that is why we landed on this as a priority. That's one reason. But I'll open this up to our working group members who are seated at that table for further comment.
Yeah, I think one of the reasons we came up with this is we as Sumera outlined, there appear to be specific linkages between different genomic drivers and different aspects of the tumor microenvironment. So having that information and knowing in detail what those relationships are could lead to therapeutic opportunities. If you see this mutation and this effect on the tumor microenvironment, specifically the immune microenvironment, you might want to treat that individual differently than if they have a different mutation with a different effect on the tumor microenvironment. Probably didn't say that as well as Nabil.
No, I just add to that is that, the beauty of these spatial methods is that you actually can resolve receptor-ligand interactions in a spatial environment, and so a specific immune subpopulation associated with a ligand that's a recruitment factor that's spatially constrained does suggest, perhaps there hasn't been examples that have been successful, but these technologies are new, and having started to play with them, let's say, I really am a believer in the resolution that you can achieve. I do think that you need hypothesis when you actually mine this data, so that very unbiased view of these things, not coupled to experimental research, I think is a bit fishing, but I think that we do need to know what the epithelial expression program is. So on the one hand, these spatial methods allow you to do a kind of rich man's laser capture microdissection to know what the cell autonomous program is. But then you have, in the same type of analysis, without added cost, you see the relationship between tumor immune in a spatial context, which I have seen actionable candidate ligand receptor interactions. So I'm confident that without a gigantic outlay of funds, that this would be a resource, but we'll have to see.
So, sorry, the mic's going around.
Oh, like a rock star? Yeah. I have no experience. Just to amplify a couple of points, I think the ligand receptor pairing from these studies has identified targets, and the biotechnology industry is really rich with emerging compounds that will prove fruitful, I think, ultimately. We need to have this information widely available to all investigators to mine. There's so much that can be done now with secondary analysis.
Thank you, Greg. Daniela, please, and then Vincenzo.
I don't know if you can hear me. Can you hear me? Yes. So I'm definitely in favor of it. I don't want to sound negative at all, but I do echo that it's like this is a tool that will provide a lot of information that is going to be hard to make sense of just using the spatial. That is a tool that I think we should combine with the traditional mechanistic study, because whatever you're going to find, you need to know what they're doing there, right? You're going to see who is in there, who is talking to who, but it's like how do we use this information? I think we cannot. I will just add some components that is like we need to then generate a hypothesis and validate the mechanism before we identify potential therapeutic targets.
Absolutely, couldn't agree more with you. So I think that the reason this is a priority as part of this working group and this forum is because it's a priority for the field, right? So it's not for individual investigators. I think most of us always advocate for hypothesis-driven research, right? But I think one of the opportunities for the foundation is to generate such an atlas that could benefit a lot of different investigators, because it would be a rich data mine, right? So, and everybody can have their own molecule that they're interested in. As those of us who do multi-omic studies, particularly single cell, we know that this is cost prohibitive. So it's really difficult for individual investigators to take this on. And it also doesn't get funded, right? Because these are broad characterization studies that are, can be called fishing expeditions. So I think that was the primary reason that we felt it's a research priority from particularly from a foundation perspective. But I completely agree with you. I think the ultimate goal would be have this as a resource, and then, have it available for individual investigators focused on cholangiocarcinoma.
Yeah, if I might add before Vincenzo, I fully agree with Daniela in this case and your comment. I think this kind of multi-omic analysis, which are very fancy and very attractive in general, they provide qualitative data, and everything must be demonstrated then in biological studies. This is fundamental, and for the new generations, that's key to show them that this is the way to go, no? Because otherwise they can be fascinated by the omic data, but this is just a tool to then demonstrate the processes occurring in cancer, no? Vincenzo.
Okay, this is a very nice kind of approach. I want just to comment about how this should be better included in the reality of cholangiocarcinoma, because cholangiocarcinoma is very heterogeneous cancer in terms of not only intratumor heterogeneity but also intertumor heterogeneity, and very importantly risk factor and liver disease, biliary disease. So I mean, this is something that is very important. Dissect very carefully the intratumor heterogeneity, but before of this, we should also consider the intertumor heterogeneity to avoid the difficulty to interpret and to do a data mining on large set of data from heterogeneous kind of cluster patients. So this is just a comment to take in consideration the subtype and even the disease that are at risk of the different subtype, especially intrahepatic cholangio.
Yeah, no, we absolutely agree with you, and that's actually a perfect segue into section 2, where we will talk about precursor states and different diseases. So thank you for that comment.
Microphone 1.
Yeah, thank you very much. I just want to, I'm Nigel Jameson from Glasgow. I'm a surgeon, but I also invest a lot of my time in spatial omics. So I end up managing consortiums that are looking at these tools in colorectal liver metastasis with a number of drug companies at the moment. And I just want to highlight, I think this is so important to do this for a disease entity where this is particularly expensive, and we have to pull together as a community. You know, I constantly, to use the fishing analogy, am swimming against the stream, raising funding for these expensive technologies to democratize it across the communities in the UK. And so I think it is important for this foundation to be aware of how important this would be for cholangiocarcinoma. For some of the points that were made regarding heterogeneity, ultimately these technologies are becoming cheaper, and also their availability in FFPE means that you can do serial biopsy studies. And I think and archival sample studies, it's single cell resolution, and that's where we're going to make impact from larger cohorts pulling together. So thank you, it's a good point.
Thank you for that comment.
I think also there are some techniques that you can combine both, no? The multi-omic analysis plus the biological demonstration. You can do cholangiocarcinoma on chip studies, precision cut liver slices. So there are techniques that you can combine both strategies together, no? And I think this should be also considered.
I'm Silvia Alfo from Barcelona. I think this is a very unbiased way to find new markers. And since these tumors do not respond to classical therapy, this is very important to find new targeted, mainly in combined therapy. This is what we believe. And the only way to find them in an unbiased way may be the spatial or the single cell transcriptomics, I think. And then we need to validate this data, but this will allow us to really discover new unbiased targets useful for combined targeted therapies. And will allow us as well to identify intratumoral heterogeneity because of this complexity. So we can really analyze both the intratumoral heterogeneity of the tumor cells and their specific interactions with specific cells of the tumor microenvironment, which I really believe will be the future for cholangiocarcinoma.
Any further comment?
So maybe I can just rephrase for some of the patients in the room. What we're asking for is to develop a multi-omic atlas, really? Is that, and then all of these things would come from that? Is that a way of simplifying?
Yes, yeah. So I think for the patients, I mentioned that we have pieces of the puzzle, so we're trying to complete that puzzle with this priority. And because we think that by completing the puzzle, we'll be able to, that will help us develop new treatment strategies.
Along these lines, what we know is that the general material within the tumor, among the tumor cells and surrounding the tumor, that's what we're calling the tumor microenvironment, has properties that by some activity within the tumor cells themselves makes it particularly suppressive of the body's immune system. It stops the body's immune system from working. We have seen evidence, I think maybe mostly in other cancers, that if you clear up this tumor microenvironment, get rid of the nasty components, and here we're talking about things like fibroblasts, collagen, regulatory T cells, immune suppressive myeloid cells. These seem to be the things that are suppressing the body's immune system. If you can get rid of those, then the tumor becomes much more vulnerable to attack by immune therapy and other therapies. What we're trying to do is understand in some detail what it is about the mutations that produce the cancer that cause the cancer to create this immune suppressive tumor microenvironment. And it's knowledge of that that we hope and expect and we're doing this at a very basic scientific level. If we understand it at the basic scientific level, we'll be able to translate that into something that changes it, puts it back the way it is supposed to be from our point of view, stops the cancer from doing itself, and becomes an effective therapy.
Atlas strategy, you get a series of tumors without annotation clinically necessarily and test them. If the goal, for example, is to identify TME characteristics that are immunosuppressive, isn't it better to go with a cohort study, a case control study of responders, non-responders? I realize that that will overlap with the biomarker group, working group, and our working group as well, but I just wanted to figure out the strategy of patient selection.
I think you sort of answered why we didn't, right? Because there was an effort to try to overlap with other groups. That's really why we didn't go too into treatment response. We do have section 3 that's focused on therapeutic resistance, and even within that section, we try to really focus it on preclinical studies to avoid overlap. But I completely agree with your point that, so this would be a starting point, right? Atlas, where are things before we treat, and then how does that evolve with treatment?
Okay, so thank you very much for the comments. We will proceed with the voting, and then we'll keep discussing.
Did everybody receive the push? Can you put your hand up if you did not receive the push? Okay.
Good.
We have about 10 people. Anyway, it passed.
Good job.
Did anybody who did not get the push object to this passing? Okay. This is just an editorial comment. Thank you so much for this recommendation. I think we will come back to the group just to ask for it to be simplified, a little bit briefer, understanding that this is all the broader remit. Thank you.
Absolutely. All right, how do I advance? Okay. All right, so that moves us to, maybe I advanced too much. I did. All right. Moves us to section 2, which was focused on carcinogenesis of cholangiocarcinoma. And within that section, those were our working group members that had really worked on that part of it. So what do we know about carcinogenesis? There are 2 aspects to focus on. One is a metaplasia to neoplasia sequence, right? So cell types that go on to from sort of precursor states to cancer. And then second is actual precursor lesions, which are defined gross anatomic lesions that can give rise to cancer. And in terms of the anatomic lesions, there are 2 main types. There are biliary intraepithelial neoplasias, or BILINs. These are commonly associated with, more commonly associated with distal and perihilar, and less so in intrahepatic. And then there are intraductal papillary neoplasm of the bile ducts, with IPNBs, that are less common. And these lesions, their molecular features have only been superficially examined, and much of what we know about them has been limited to the epithelial component. The other part of carcinogenesis is cell states. So these are cell states, cells present in high-risk patients, such as patients with primary sclerosing cholangitis, or PSC, which is a premalignant disease, without any gross anatomic changes. And there have been a number of generic stemness markers that have been identified in cholangiocarcinoma, but their relevance in stratifying risk in patients is not known. Specifically in patients with pre-malignant diseases such as PSC is not known. And Billings, there is limited literature suggesting that there is immune diversity, there's a reduction in certain types of immune cell populations, such as T lymphocytes, and compared to the non-tumorous biliary epithelium. And there are also a number of genetic models of cholangiocarcinoma that provide a mechanism to explore earlier stages of disease by looking at these precursor lesions, which may be a bit elusive in patients. So they're a good resource. So based on this, what are the knowledge gaps? The true frequency of precursor lesions is not known, and neither are the determinants of these precursor lesions, whether there are any differences in their prevalence, their presence between disease etiology across lifespan. And we also have a paucity of information on the cellular composition, the epigenetics, proteomics, and transcriptomics of these precursor lesions. And the bulk of animal models that exist, they really model end-stage disease. But it's likely that many of these models, or it's possible that many of these models may transition through a precursor stage, but that is not known. So based on the knowledge gaps, Section 2 identified this research priority. To define and exploit the biology of precursor cell states and define them using spatial approaches, proteomics, transcriptomics, metabolomics, to human tissue, but also animal models that would allow us to conduct functional validation studies to really examine the relevance and risk of these states, and to do so in high-risk patients with pre-malignant diseases such as PSC and cirrhosis for intrahepatic cholangiocarcinoma patients, so on and so forth. And we would leverage this knowledge to develop chemo-preventive strategies for high-risk patient populations. So with that priority, I think we can open it up for discussion before we go on to voting.
Lights up, please.
Microphone over there.
Thank you very much for all of these efforts and the work that is being put up today. One quick question I had is that we have data from a lot of other cancers, particularly hematologic, but also some others, about these sort of non-malignant clonal proliferations. Is that something that you considered having being part of your strategy, which is a little distinct from the spatial effort?
Sorry, are you referring to what's known about precursor lesions in other cancers, and how do we think that informs what we know about CCA? I don't know if I fully understood.
Yeah, I apologize. Let me try again. My impression is that in some other tissues, there are non-transformed cells that over time will outgrow some of their normal neighbors, and these can usually be identified using like non-driver oncogenes and other, small mutations. And I'm curious if that could be part of understanding the pre-malignant state for cholangiocarcinoma.
Oh, yes, absolutely. I think that's really that's part of what we're getting at here with trying to define these cell states. Any other comments from our working group?
I'd just like to, good morning everybody, and I'd just like to remind everyone when you step up to make a comment to please identify yourself and your institution, just as we can get to know each other.
I guess Ben Stanger, UPenn. So part of this working group. This priority is informed by the fact that for virtually every cancer, there's an identifiable precursor lesion that we can see histologically and often anatomically. In the colon, that's a polyp. In the pancreas, these are Pannin lesions. In melanoma, there are nevi. we don't have a good handle on where these cancers, where cholangiocarcinoma comes from. It's a fundamental, they don't just come up randomly, they come from some type of precursor. There's controversy in the literature and from our own experience on what the real prevalence of this is in the literature. In, say, autopsy studies or resection studies, they're quite common in the experience of some of our clinicians. They hardly ever see them on pathology reports. So this is a big knowledge gap.
Can we see the recommendation, please? The next slide.
Oh.
Yeah. Microphone 2, please.
We stop the poll, please. We're not ready.
Yeah. Stop the poll, yeah. We can...
Just a comment, sorry, Mairead McNamara, Medical Oncology in Manchester. Just a comment on the second, the cancer interception. So, you know, from a clinical point of view, we would never think about giving chemotherapy to non-invasive disease. So I'm not so sure that that part is what you would do clinically. Should you not be thinking about earlier surgery? Or, you know, rather than, you know, our thinking is it's not invasive disease, and with other disease groups as well. So I just think the second part needs to be reworded or to think about that again.
Also prophylactic treatment, no? For example, the aspirin trial in patients with PEC is ongoing now, prospectively, particularly to see if that prevents the development of cancer. So not only is actually chemotherapy, maybe...
Yeah, so chemotherapy, yes. I'd be a bit...
Agree, prophylactic treatments,
yep.
Maybe more wide. Thank you for the comment.
Word you want to use for it, but chemopreventative certainly has been used absent, like, DNA damaging agents, standard, chemopreventative, like I'm thinking about exactly the aspirin and things like that. So I think that's what we were thinking as a group from that standpoint, is that there will be some targets that can be hit.
So I think chemopreventive is a broad word and a broad terminology, but there are many agents that can be chemopreventive. Many of these are quite benign, statins, et cetera. So that was in the context.
Chiara? Yeah.
Chiara from Glasgow. I absolutely recognize the need for better understanding preneoplastic lesions and the transformation. I think that we have seen in the previous recommendation the importance of spatial approaches, but given how little is known about preneoplastic lesions and development, I'm not sure I would limit this recommendation only to spatial approaches for this one. Should we be more, instead of applying spatial approaches, it should just be more broader and more general?
Like multi-omic approaches, is that what you're thinking? Yeah. Including spatial, so we can reword that, that's, yeah.
Yeah, I agree. It's too narrow to focus on spatial. We discussed also previously that. I think some rewording here would benefit.
Should we go for the vote?
Yeah, maybe we should go to the vote and then...
Please open the vote. Can we close the vote? The clock is not ticking down. Thank you.
Thank you.
I'm on top of the world, hey. I'm on top of the world, hey. Waiting on this for a while now. Paying my dues to the dirt. I've been waiting to smile, hey. The hope it ain't for
Well, it was approved. So thank you very much. Maybe we can take into consideration some of the comments to rewrite the sentence and basically have the same objective but being more broad. So thank you very much.
All right, so that brings us to our final section, section 3, which was focused on mechanistic underpinnings of therapeutic resistance in cholangiocarcinoma, with subsections of chemotherapy, immunotherapy, targeted therapy, and optimal disease models, because again, we're the discovery science group. And so what do we know about published resistance, the published literature as it relates to resistance to chemotherapy? We know that there are multiple overlapping mechanisms of therapeutic resistance: intracellular drug concentration, changes in molecular targets, anti-apoptotic signaling, DNA repair, so on and so forth. And then there are also indirect drivers of resistance to chemotherapy, namely tumor microenvironment and epithelial mesenchymal transition, or EMT. What has the published literature taught us about resistance to immunotherapy? We know that cholangiocarcinoma is typically an immune-resistant tumor type. The response rates to anti-PD-1 monotherapy range from 5 to 10%. Cholangiocarcinoma tumors tend to have a low tumor mutation burden, low neoantigen burden, and all of that can contribute to primary immune resistance. And there are subpopulations of patients with mismatch repair deficiency who have a high response rate. And the tumor microenvironment in cholangiocarcinoma, and this is something that we've touched on a little bit earlier, is characterized by a very dense desmoplastic stroma with accumulation of immunosuppressive cell types, such as tumor-associated macrophages, regulatory T cells, and accumulation of immunosuppressive oncometabolites as a result. And these immunosuppressive cell types can secrete immunosuppressive cytokines, which lead to suppression of cytotoxic T cell activity and promote tumor progression. And we also know that CCA is genomically heterogeneous, and that can impact response. What do we know about resistance to targeted therapy? So this is two broad categories: acquired resistance and primary resistance. We know a bit more about acquired resistance than we do about primary. In terms of FGFR inhibition, NTRK inhibitors, KRAS, BRAF, there are several mechanisms of resistance that have been identified, including kinase domain mutations, bypass receptor tyrosine kinase and MAP kinase pathway alterations, such as KRAS mutations, MET amplification. And there's also evidence for non-genetic signaling feedback via pathways such as epidermal growth factor receptor, or EGFR. In terms of resistance to IDH1 inhibition, there can be secondary IDH1 and 2 mutations that confer resistance, and there are also RTK-MAP kinase pathway alterations, but many cases don't show acquired genomic alterations, suggesting that other mechanisms are likely. In terms of primary resistance to FGFR inhibitors and HER2 inhibitors, there are TP53 mutations and CDKN2A mutations that can confer primary resistance. The published models of resistance, we have both in vitro models and in vivo. The in vitro models include cell lines, organoids, spheroids, precision cut tissue slices, and there's a need to increase the complexity to gain a better tumor model by including components of the tumor microenvironment and leveraging microfluidics. In terms of the in vivo models, there are a few categories of in vivo models. There are carcinogen-induced models that are useful to study the expression of genes involved in intrinsic resistance during carcinogenesis. There are also genetically engineered mouse models, or GEMs, that permit that allow us to study the role of specific oncogenes and tumor suppressor genes in multi-drug resistance. And then there are engrafted models that permit drug screening in resistant cells and help evaluate the mechanisms of chemoresistance. And these could be both patient-derived xenografts or PDXs, which preserve the original genetic and epigenetic features and surrounding stroma. And then also immunocompetent allograft syngeneic models that have a fully functional immune system and permit testing of immunotherapy agents. Novel readout technologies that are emerging and should be leveraged include multiplex imaging and spatial transcriptomics. So what are the knowledge gaps as it relates to resistance to chemotherapy? We don't have a good grasp of the multi-omic features that are associated with resistance to chemotherapy, and these could be driver-specific or combined patterns of resistance tied to identifiable tumor subsets. And then the evolution of therapeutic resistance, right? So this is something we briefly touched on earlier. We don't have a good grasp of that either. Knowledge gaps in terms of resistance to targeted therapies. For acquired resistance, there are a number of unanswered questions. How does prior therapy affect landscape of resistance changes? How important is genetic resistance versus other mechanisms? What's the role of epigenetic and transcriptional programming and immune tumor microenvironment changes? And what's the specific function of receptor tyrosine kinase and RAS alterations in driving resistance? For primary resistance to FGFR and or other RTK inhibitors, as well as IDH1 inhibitors, we don't have a full understanding of the impact of the tumor microenvironment and immune heterogeneity, the impact of various co-mutations on signaling feedback and immune evasion, and the role of metabolic adaptation. For PRMT5, this is a new pathway, and we need to learn more about the determinants of resistance beyond MTAP status. Models of resistance, as I mentioned, we have a variety of models, but there are several knowledge gaps. For in vitro models, we have to move from drug sensitivity in tumor cells towards models that incorporate the tumor microenvironment, and which would allow us to dissect the crosstalk between the different cell types within the TME, involvement in therapy resistance and pathway analysis. And we also don't know the role of environment and pollutants on development or acceleration of tumor growth, and how do we model that? What concentrations and exposure times are needed? And we don't have a way to model the high tumor recurrence rates that occur after surgical resection. In terms of in vivo models, there are comparative studies on intrinsic resistance in carcinogen-induced tumors versus acquired resistance during tumor progression or after exposure to chemotherapy are lacking. And the ability of GEMs to predict clinical response remains uncertain. What is their fidelity to replicating human chemoresistance mechanisms? It's also unclear whether PDXs can fully preserve the dynamic tumor stroma interactions that are present in human tumors. And the extent to which the immunocompetent allografts can replicate the immune response is also not known. And there's a need to leverage big data analysis model systems for both in vivo and in vitro and combine them to correlate the model with the outcomes in patients. So this was based on those knowledge gaps, this was the proposed research priority for Section 3, which again focused on mechanistic underpinnings of resistance to systemic therapy and really looking at it from, as I said, a mechanistic discovery science level. So define the integrated multi-omic determinants of primary and acquired resistance to selected therapies, including defining the adaptive changes in the TME driving resistance across the different molecular and anatomic subtypes of cholangiocarcinoma with, of course, validation in relevant preclinical models. So I think we can open that up for discussion.
Lights on, please. comments?
So maybe we can see the recommendation.
Yes.
Any comments from the audience on this recommendation? Any additional comments from the working group?
Microphone 3.
Okay.
Yeah, microphone 3, please.
Hi, this is Bob Silverman from Sunfloor. You had a lot of knowledge gaps in there, and what I didn't get was a sense of, do you have priorities, and how long is it going to take? Are you going to do this all at once? Actually, for none of the recommendations, I never got a sense of what the time frame was for finishing the project. So I wonder if you could speak to that. There were quite a bit of knowledge gaps, and I didn't get a sense of what the priorities might be.
Yeah, so I think the knowledge gaps can inform the priorities, but it's challenging for one working group to have multiple priorities to address all the knowledge gaps, right? So I think the reason we presented the knowledge gaps is so we understand what the landscape is. And from within those knowledge gaps, we prioritized specific, priorities. So that's one. In terms of time frame for priorities, I mean, the different recommendations, I don't think there is a time frame, right? Because one of the purpose of identifying research priorities is to help inform future RFAs, and those RFAs can use these as a general guidance, but the time frame would be related to a specific mechanism. So I don't think we were charged with identifying timeframes. It was more sort of what are the areas that we really should be focusing on. But I'll let Juan.
Yeah, just a very quick comment to reply to that. So Samira is absolutely right. What we're doing is we're identifying the priorities. It's the what. The how these things are delivered would then be part of an RFP call with all of the details and the timeframes included.
Thank you.
I mean, all the recommendations are good. Why not just do them all?
Are you funding it?
So do you have priorities among the recommendations that you're presenting?
I think what we're presenting as the priorities are actually our priorities. The 3 recommendations is what we prioritized based on what we had learned from our literature search and the knowledge gaps we identified.
A lot of things that we discussed, and I'm sure the other working groups discussed, that did not make it onto this list, just so that you're aware that there has already been a winnowing process.
Okay. Nilo, do you want to add on here?
I was just going to harken back just to yesterday when we first started, that the goal of these days is really to list out things that we really feel as a community are important, but we actually are trying not to prioritize and just state that these are things that are meaningful in terms of research as we go forward. And so I think the way that you've done it is a nice way to make sure that we're being as cohesive or complete as possible, but still allowing that individual flexibility for different funding guidances.
Okay, should we proceed to the vote?
No, so we listed as examples both approved therapies, which would presumably have the most potential to be acted upon more quickly, and then we had targets that have been pretty elusive, like PRMT5. And so I think, I just wanted to reiterate, our whole point was I think we can solicit proposals that are in these areas. We sort of given a guideline, but the most actionable would be building upon an approved therapy. So I think it's sort of, for most of us, sort of natural where we would invest. But an exciting proposal for a new target could also be explored.
Thank you.
Thank you.
Can we go to the vote, please, in the back?
Excellent.
Excellent.
Oh, awesome. Okay, I was going to say when we didn't get comments that are we going to get like 100%, but I'll take that.
Okay, good. So I think that sums up the session very well. And thank you for joining the first part of the science session. And thank you also for the insights shared by the Working Group 4.